A very good morning, students. Now this is the dissection of the shoulder joint. Now the dissection of shoulder joint is highly disappointing because most of the ligaments, especially the anteriorly placed glenohumeral ligament, is not seen properly. It is seen from inside, not from outside. Similarly, the tendons of the subscapularis, supraspinatus, infraspinatus, and teres minor. See here, this is the subscapularis. This is the long head of the biceps muscle which takes origin from inside the shoulder joint, intracapsular origin from supraglenoid tubercle. Okay, if you see this subscapularis, it goes and blends on anterior aspect with that of the capsule. Similarly, this is the supraspinatus muscle. See this supraspinatus muscle, it will go and it will go on to the top of this greater tubercle of the humerus. Similarly, the posterior aspect, this infraspinatus, they all go and blend with the shoulder joint. The capsule of the shoulder joint from anterior aspect, from superior aspect, and from posterior aspect. Okay, and these muscles, that's why they are called as rotator cuff. It is different, very difficult to separate these muscles or muscles of rotator cuff because they blends very tightly with the external surface of the capsule. Only on the lower aspect of the capsule is not supported or not fusing, right? And there is a long head of the triceps. So I will cut this long head of the triceps to go to the very close to that of the capsule of the shoulder joint. Okay, and this long head of triceps which takes origin from the infraglenoid tubercle. So I have cut the long head of the triceps. At the same time, I am also cutting this teres major muscle. Okay, so just want to free the shoulder joint capsule from all the side. So whatsoever we will be able to see here, we will try to see. So this is from the inferior aspect of the shoulder joint, okay, where this capsule is seen. I hope that you are able to see this white capsule of the shoulder joint where it is unsupported. Now I will try to remove this infraspinatus muscle from the posterior aspect. And in the last video also I have shown you that there is a bursa here between the muscle and the head of the scapula, that is glenoid, this is scapula, glenoid scapula, okay, glenoid cavity of the scapula, posterior margin of the, I can feel here the posterior margin of the glenoid cavity, and this is the bursa which minimize the friction between the glenoid margin of the glenoid cavity posterior and to that of the infraspinatus muscle. And sometimes this bursa may communicate with the capsule. The capsule or synovial capsule is deficient and the synovial membrane may protrude in this bursa. Not here, it is not protruding. This capsule is seen here, okay, capsule is seen here. So I will try to reflect as much as possible, but it will not be possible because it is very firmly attached onto the posterior aspect. Similarly, the supraspinatus, I have not given the cut into the supraspinatus because here is the presence of the acromion process. You can see acromion, this is the coracoid process is here, this is acromion, and this ligament which extend between the coracoid and acromion process is the coracoacromial ligament. See in this my farce, this is the coracoacromial ligament is here. This is the undersurface of the acromion process where I am putting my finger, and this forms a coracoacromial arch which forms a socket or from above for the head of the humerus here. It cannot be displaced because coracoacromial arch which is formed by the acromion process, under surface of the coracoacromial ligament, and coracoid process. They support it from or protect or prevents the upward dislocation of the head of the humerus. Now, this below this acromion arch, coracoacromial arch, there was a big bursa, and I have removed this big bursa. See this, still this layer of the big bursa is here. You can see that my forceps is in the cavity of this bursa. So I will cut this bursa, okay, and this surface of the head of the humerus, through which here is passing the supraspinatus tendon towards the greater tubercle, okay, supraspinatus, okay. Here is the infra, and the teres minor will come here, okay, it will come here. So infraspinatus, teres minor, and the supraspinatus is here. What I am going to do here, since you have seen an important ligament, coracoacromial ligament of the shoulder joint here, which is an accessory ligament, okay, I am cutting this ligament so as to trace the supraspinatus muscle, which is going beneath it right up to its insertion, if it is possible. On its undersurface, it will be adhering to the capsule. So I am cutting this coracoacromial ligament from here. So I have removed the coracoacromial. Let me detach it from this acromion side. Okay. So I am detaching this coracoacromial. So this coracoacromial ligament I have removed. Now I can trace this supraspinatus muscle, which is here. Just a minute. I will trace this supraspinatus muscle towards its insertion. Now you can see the supraspinatus muscle here. I will just cut this fibrous band, and then we'll try to just trace it right up to its insertion, okay, if I can, which is difficult. So I'm just removing this. Okay, now you can see the part of the tendon. See this part of the tendon going deep to the acromion process. See, this is the acromion process, and along with the finger, this tendon of the supraspinatus is going. I can just lift this tendon. See this tendon? It is going here, okay, supraspine. I am not able to trace it further. I am not able to. So this is all around surrounded by the capsule, okay, capsules and muscles forming the rotator cuff. What I can do that I will have to go inside the capsule, cavity, and you can see this is the long head of the biceps, which takes origin from supraglenoid tubercle and comes through the bicipital groove, taking along with it the synovial membrane, okay, synovial membrane. I will give a cut to this, capsule all around, okay, and will just separate the scapula from that of the humerus, Better I will give it this cut very close to this glenoid cavity margin, okay, margin along the glenoid cavity, as I am giving here, okay. I have opened the tendon from cavity of the shoulder joint from behind. Now cutting it from the lower side, that is inferior aspect, which is quite lax, and then we'll try to cut it from the anterior. Okay, then I will turn it and will try to cut deep to the subscapularis. Okay, it is already torn here. And then supraspinatus, yes. Just a minute, please. Let me cut this tendon, yes. I have cut the tendon very close to the margin of the glenoid cavity, and just removing this. Okay, I have just removed this glenoid cavity, okay. you can, I mean say this scapula from the joint, you can see the glenoid labrum, okay. See this, it is a fibrocartilaginous disc here, okay, and this will, the apex here is continuous with that of the tendon of the, I mean to say, long head of the bicep. See this fibrocartilaginous disc. I will lift this fibrocartilaginous glenoid labrum here so that you can see it is adhering. It should not adhere. Some pathology is here. See this deep to between the, in the tip of my forceps, I am trying to lift this glenoid labrum, okay, but it is adhering. It should otherwise normally not. Yes, here it is not. See this is the fibrocartilaginous rim called as the glenoid labrum, okay, and this is that fossa of the glenoid cavity, bony, which is covered by the hyaline cartilage. It is covered by hyaline cartilage. The capsule is attached to the margin of this scapula, okay, on the glenoid fossa, on the margin, okay, just at the margin it is attached here, and then it comes and covers the under surface of the capsule, which we will try to see it here. See this, okay. So I will cut it from one side and will try to see this is the long head of the biceps, which was intracapsular but extra synovial. This is going, you can see here on the inferior aspect the capsule is away from the margin of the head, and it is onto the neck, it is onto the surgical neck of the this humerus. See this how, so this much part is of the neck on the inferior aspect is quite at a distance. The capsule is attached at a, and thus this glistening membrane is nothing but the synovial, but as it comes above, it is close to that of the margin of the head. I will cut it from here and will try to see the this, I mean say ligament, glenohumeral ligament, superior, middle and inferior glenohumeral ligament, okay, which are real difficult to see here, okay. Sorry, I have cut it from through this glenohumeral ligament, okay, probably. Yes, this is the tendon of the subscapularis. So this is the anterior side, and in this wall there should be, no, I am not getting it, okay, I am not getting it, the three slips of the, this is the tendon of the long head of the bicep, this is the posterior aspect. I will give a cut and we'll see the posterior aspect. Okay. You can see here, still one more cut it needs. So that I can reflect the capsule and see the cavity of surrounding to it, okay. So these were all tendons which are very firmly fusing with the capsule on its outer side. The capsule of the, I mean say the tendons which forms the, I mean to say, rotator cuff. See this, I have just removed it, okay, this capsule, okay, and see this, it is just lined by the synovial membrane. This glistening membrane is the synovial membrane is here, okay, it is synovial membrane is here, okay. So this is the head of the humerus you are seeing from all around. Now there are some osteoarthritic changes. See the membrane, this hyaline cartilage is not normal, okay, that is eaten up, okay, or destroyed here. It is destroyed due to the old age, okay. So this is that head of the humerus inside the shoulder joint capsule. As I have told you in beginning, the dissection of the shoulder joint is very disappointing, okay, because of the fusion of the tendons of the rotator cuff onto the surface of the capsule, outer surface of the capsule, and the ligament glenohumeral is seen only from the inferior, I mean say internal aspect, which is okay on the anterior aspect. I am trying but not getting, okay, trying. So there was a gap here, see this gap, and this was going to the subscapular bursas, that means the synovial membrane through the gap, and it is said that just above this gap lies the anterior limb of the glenohumeral ligament, and below are the two, that is the middle and inferior limb. Okay, this is just a thickening of the capsule, okay, which forms the glenohumeral ligament. Okay, a transverse ligament around this long head of the tendon of the long head of the biceps, and this is bridging the margins of the greater and lesser tubercles in the bicipital groove. Okay, this is a transverse ligament. This is the third ligament beside the glenohumeral and the coracoacromial ligament. Okay, the fibers, the transverse fibers extending between the medial and lateral lip just to retain the tendon in the bicipital groove. That is not of much significance. Okay, so I hope that what I wanted to show you is over glenoid labrum, the cavity of the glenoid fossa, okay, lined by hyaline cartilage, head of the humerus lined by the hyaline cartilage, and the capsule attached and its extension lower down on the medial side into the surgical neck of the humerus that I could show you. Okay, sorry for disappointing you because the dissection itself is not very, good. It's very difficult to dissect all those things. Okay, thank you very much for watching a short video on the shoulder joint. Most of the thing in shoulder joint, they are theoretical things. Okay, they are. So you should remember all those capsules, synovial membrane reflection, ligaments, okay, all these, and the tendons relation, that is of rotator cuff. Thank you very much for watching this short video.